Can I just have the next slide, please, Graham? Thank you. So just very quickly, some housekeeping. If we can keep ourselves on mute and our camera off when we are not speaking, presenting or asking a question, that would really help with connectivity. We do have a Twitter presence, and for all placement related activities, we are using the hashtag AHP Practice Learning. This is the national hashtag that has been promoted by the national team at Health Education England. Just trying to see if I've missed out on anything there. Yep, that's fine. Can we have the next slide, please? So why are we here today? So we are here to hear from people who have tried something different as part of their placements. We're also here to understand the picture of placements, their shortage, cancellations, and the effect that might have on our students and educators as well. So it's really an event to help people think out of the box and inspire, and maybe something different from all of us just thinking about COVID at the minute, though it's unavoidable. We hope that after each presentation has spoken, there will be about 5 to 10 minutes of Q&A. So if you have a question, please raise your hand and I'll just invite you to speak. If you don't want to speak, you can put it in the chat box, but it's just easier if you just speak when invited, please. If you have any general comments or just want to keep in touch, pop your email ID in the chat box so we can get out the slides to you as well. If we do run out of time and you have more questions, you can forward it to the project team. We'll put our contact details right at the end of the presentations have taken place. So really, that's my little spiel. Now, without much further delay, I'm going to hand you over to Vicky from University of Liverpool. Vicky will introduce herself. So Vicky, over to you.
Thank you, Nisha. So I'm Vicky Barnes-Brown. I'm an occupational therapy lecturer and practice placement tutor, but I'm also chair of the School of Health Sciences Practice Placement Working Group. So Nisha and the faculty have invited me today just to give you an overview of the 5 AHP programmes that we have at University of Liverpool and our primary reasons for placement shortages. Can I have the next slide, please, Graham? Okay, so first of all, just an overview of our current numbers of students within year one of each of our programmes. So we've got 5 AHP healthcare programmes at the University of Liverpool. Diagnostic radiography have 60 students in year one, occupational therapy 70, orthoptics 52, physiotherapy have 80, and then therapeutic radiography have 42 students. So all of these numbers have increased over the past number of years, and obviously that in itself can contribute to having an issue with numbers of placements that we actually require. Okay, next slide, please. So what I'm going to do over the next couple of slides is just talk to you about each of our specialities and each of our programmes and the primary causes of placement shortages per profession. So for our diagnostic radiography programme, the need for students to have access to imaging equipment is a big issue. So obviously there's a limit to how many students can be allocated per X-ray room and per scanner. There's also a requirement for experience related to a variety of different radiographic examinations and environments required for first post competency. So, for example, some of our private providers and specialist trusts might not have sufficient numbers of such examinations or exposure to environments such as A&E and theatre. So there is limitation to the numbers of students that can actually, go to those particular areas. There's also a restriction of placements to the academic year timetable. So this means that sometimes different years of students are out at the same time. Different trusts have varieties in their shift patterns. So some trusts are able to rota students out of hours and at weekends to be able to enable greater capacity, but other trusts are more limited, depending on the types of activities they perform. There's also in a variety of trusts equipment replacement programmes which are essential for updating equipment within this profession, but this can have a temporary limiting factor. So X-ray rooms may be out of action for some time, limiting student capacity at any one site. And then obviously there's COVID. So this has had an impact due to social distancing requirements in rota patterns, but especially with regard to placement risk assessments and students with health conditions being unable to go on placement because diagnostic radiography is considered a high risk area within trusts. Next slide, please. So within occupational therapy, we've had issues with staff predominantly in community mental health and learning disabilities specialities who are working at home throughout the pandemic. There's also been issues with staff shortages due to staff sickness, staff shielding, needing to isolate. But OTs in many areas have also been redeployed across trusts and not working in their usual roles, which has limited capacity. And then this year, due to the pandemic, we've been unable to use any of our international placements. So usually we have placements at National University Island Galway and Southern Cross University in Australia for some of our second year students, and we have a placement exchange. But due to the travel ban, these have not been able to go ahead this year. We also have placements in the Isle of Man, and again, we mightn't be able to use those placements if travel restrictions continue into next year. Next slide, please, Graham. Okay, for the orthoptics programme, again, there's been COVID-related reasons for cancelling placements, such as limited space to accommodate students in clinical areas. Obviously, staff shortages, which is typical across all of the professions, and staff redeployment. There's also been issues with outsourcing of clinical workload to private companies, and then clinical pressures, meaning catch-up clinics were having to be run due to activity being cancelled during lockdown. Within orthoptics as well, because our students travel across the country for placement, there's been specific concerns from our out of area placements about students travelling from a tier 3 or a high risk area. So this was, pre the December lockdown. And then concerns about procedures if students became ill on placement or had to isolate. And then there's been the usual reasons for placement cancellations as well, with clinical tutors leaving, staff having to support newly qualified staff on preceptorship periods, or moving on to electronic patient records. Next slide, please. Within physiotherapy, time has been a factor, and that was time required to identify and set up new placement areas for the physiotherapy placement tutor. There's also a lack of knowledge about services within existing provider organisations who are currently not offering placements to us, and this takes time, obviously, to set up. There's been some difficulties perceived by some placement providers of taking more than one student at a time, but obviously that's not typical of every area, and you'll certainly hear that in Malcolm's talk later, where he takes several students at a time. There's a culture within some organisations of seeing students as an intermittent addition to the workload, rather than a continuous part of the team. And sometimes it can be due to the chain of communication. So, for example, an educator asked recently why they hadn't been allocated any students, but the trusts had declined 2 placements that were actually sent to them. So sometimes communication can be an issue. And then again, like every profession, COVID has been an issue with reducing physical capacity of workspaces and some services being discontinued. One major factor within our community placements, particularly for occupational therapy and physiotherapy, has been the need for students to have their own transport, and that has been a big factor in us not being able to use some community placements. Next slide, please. So for therapeutic radiography, the main issue within this profession is time in the department and maintaining social distance. So the departments have been managing this really, really well with a hybrid approach. So between students being on site and then having some online but very clinical teaching done by the clinical tutors. Okay, next slide, please. So now I'm going to look at our placement cancellation figures. So within 3 of the AHP programme, there have been some cancellations. So within occupational therapy, there was 11 year 1. So this is our 1-week observational placements that were cancelled. We had 2 year 2 placements cancelled and 5 year 3 placements cancelled. Orthoptics had 30 placements cancelled. So this was 15 sites cancelling placements, which meant that 30 students affected 30 students. And so far within physiotherapy, we've only got 3rd year cancellations because the requests for 1st year and 2nd year placements only went out at the beginning of December. So we don't know how many placements will be cancelled for next block yet. Even though diagnostic radiography have not had any placement cancellations, one local hospital has not been able to increase their capacity and another have reduced their capacity, both due to X-ray room replacements. And then in 2019, diagnostic radiography lost 3 placements to another higher education institution and were supported by a local trust to take their students instead. Okay, next slide, please, Graham. Okay, so this slide just details the AHP placements or experience that have been difficult to source per profession. So within diagnostic radiography, it's not a placement as such, but a particular area of practice. And this is becoming more limited, which is general X-ray, which is obviously essential for our students to practice their basic radiography and radiographic positioning. So obviously with the advent of digital imaging and digital imaging equipment, trusts have replaced a lot of their older X-ray rooms with more digital equipment, which is a lot more efficient, but also then limits the numbers of students that can actually work in there. Within occupational therapy, as I mentioned earlier, we've been really struggling with community mental health, secure mental health and community learning disabilities placements. And that mainly has been due to the way that staff have been working from home, but also other issues such as students not being car drivers. And then community physical health, we've had the issue with students not being car drivers and hospice and palliative care services not accepting or able to accommodate students. Within physiotherapy, acute respiratory experience can be an issue because employers often ask specifically for this experience in job descriptions. And then outpatients and community placements have been reduced due to the effects of COVID. Within therapeutic radiography, it was just the limits on the amount of clinical time in departments due to social distancing measures that are in place. And for orthoptics, you'll notice that they're not on the slide. It's because no one experience is difficult to source. The challenge has been the numbers of cancellations for this particular profession. Okay, next slide, please, Graham. So what have we done so far? What creative solutions have we implemented? So within therapeutic radiography, there is a trial placement at the minute within the Proton Centre at the Christie Hospital, and this is for 6 Year 2 students and is following a national bid. So they've managed to increase student numbers at the Christie, also Clatterbridge and Preston are taking extra students, and then a private provider, Genesis, has been set up in Sutton Coldfield. Within occupational therapy, we've developed project placements for Year 3 students who are shielding and short of a week's worth of hours to meet the professional body requirements. We also developed a virtual placement week for 10 Year 1 students who were unable to go on placement either due to not being occupational health cleared or their placement was cancelled at short notice. We're also looking at split placements where 2 students will go to one placement site. One student will go for the first half of the week, the second student will go for the second half of the week, and then they'll both have a service improvement project to complete. And then we're also casting the placement net further afield. So within occupational therapy and some of our other professions, usually we place students close to the university. However, we're having to cast the placement net further afield. So in radiotherapy, this has been in Birmingham and Scotland, and in occupational therapy, we've set up some placements in Bury and Wakefield. Within the diagnostic radiotherapy programme, they're utilising some spare summer capacity to enable their pre-registration masters students to go on placement within this time. So next slide, please, Graham. So obviously there are risks. If we don't get students out on placement, then there are risks of students not being able to graduate in July 2021, and therefore they will not enter the workforce. Also, with limitations in placement, there is the potential for graduates to require further support or preceptorship due to clinical time that is lost. And the other risk is that our placement need or demand will continue beyond this academic term into the summer period for semester 1 of 2021. Okay, next slide, please, Graham. So thank you for listening, and obviously I'm happy to answer any questions, but what we'd also like to do is thank all of our placement providers, because obviously we couldn't send our students out on placement without you, and particularly in occupational therapy in this past week, then the AHP faculty and Nisha in particular have been instrumental in plugging our placement gap. We were really short of placements for our Year 2 students. So thank you for being able to help us with that.
Thanks, Vicky.
Okay,
Fabulous presentation. Thank you.
Thank you.
I would like to open the floor up for any questions people might have. So if you just want to put your hand up, if you have a question. I can see a hand up, but I cannot. Yeah, whoever you are, do you want to come in, please? Claire.
Hi, I think that's me. Can you hear me?
Yeah, I can hear you.
Yeah, hi, it's Claire here. I'm an OT at Warrington Hospital. I myself have been allocated one of Liverpool's PP3 students in January, and at the moment I'm non-patient facing. I'm just wondering whether, Vicky, you've had any experience of this in the last couple of months with the pandemic, and if so, whether anybody came up with some great ideas in terms of kind of any alternative learning opportunities that we could provide to make sure that the student is still able to meet her learning objectives.
Yeah, so Claire, it'd be great to have a meeting with you probably early in the new year, and then what we'll do is come up with some solutions, maybe around a service improvement project that the placement that the student could do that would support you and your team, but would also contribute to the students' learning outcomes. So the major factor or the major issue that's been a problem for students to do non-patient facing roles has been the use of technology and some information governance issues within trusts. So as long as those things can be solved, then obviously this type of placement can go ahead. But I'd be happy to meet with you, Claire, and discuss your individual needs.
That's great. Thanks, Vicky.
Vicky and Claire, can I just add to that as well? Warrington are part of the clinical placement expansion project, Claire, you may have heard. And one of the things we are doing is looking at procuring laptops as part of the project. Of course, the information governance side of things, which have to be sorted then at each organization level as well. We are also looking at developing a toolkit for remote placements as well. So if there are any people who would like to join those work streams from the Cheshire, Mersey, Wirral area, we're still accepting volunteers. The work streams start only in the new year. So yeah, you can get in touch with us as well if you want to be part of that work as we think through these strategies.
Thanks, Nisha.
Thank you. Is there any more questions at all, please, for Vicky? Yes, we've got one more hand up. Maria, would you like to come in?
Hi, hi Vicky. It's Maria Yon from Cheshire Royal Partnership NHS Trust, and we've worked together for years now. Just a quick question: could you give like an example of what a leadership placement would look like, or what a project looks like, the sort of thing that's worked for students?
Yeah, of course. So obviously within the AHP faculty, I've been talking to Nisha recently. So there is an opportunity for students to do sort of 2.5 days a week clinical, and then 2.5 days a week maybe within the faculty as a leadership placement. The other things is that we've set up service improvement projects for students to do. So particularly third years last year who were shielding. We've asked trusts for particular service improvement projects, and then they've done those remotely. So one of them was around evidence base for occupational therapists working in long-term conditions. One of them was around setting up a new referral form for an occupational therapy service. And then one of them did a project around setting up some paediatric leaflets. So again, you know, the service improvement project should give an added benefit to your service. You want it to be useful to the service as well as matching the students' learning outcomes. So again, more than happy to support you with that if there's things that you think that, you know, you could offer a placement, but it could be a different type of placement.
Okay, and what does a leadership placement mean?
Can I come in on that, Vicky?
Yeah.
Maria, so there's been several examples now nationally, and there was a webinar just last Thursday from Health Education England. And what it basically means is leaders, be it clinical leaders, operational leaders, team leads, they've actually had students with them in a hybrid placement or in a pure leadership placements. The hybrid placement would be they do part clinical, but then part they are with that leader to understand what their day-to-day looks like. As part of that, they would manage 1 or 2 projects depending on their time scale. The projects may not be connected to the clinical work they're doing, but it's to focus on understanding, you know, awareness of self, how these leaders are actually working behind the scenes as well in their own trusts. So the meetings they attend, or understanding leadership styles, understanding appreciative inquiry and coaching skills as well. So the focus on leadership placements is immense at the moment, because there's a recognition that students need to have not just clinical skills, but also, you know, the 4 pillars of advanced practice. They need to have those leadership skills, research skills, and education skills as well. So if you're interested, HE's webinar will soon be out on a recording on their platform, and it's a great experience to hear what others have already done in terms of leadership. I hope that puts some context to that.
That's really helpful. Thank you. Really interesting.
Thank you. Any other questions for Vicky? Just looking into the chat box now. I'm just trying to go between chat box and hands. Yeah, there is a comment from Jane to say that QI could be part of leadership placements as well. Thanks for that, Jane. And Soraya has put that you understand that leadership placements are for final year students. Does that mean we can offer for first couple of months of the final year? So Soraya, I think it's quite new. So I would say if you're exploring that, talk to your HEIs, because they might be able to get the right people for you, the students who are looking to do those type of placements as well. I don't think it's stipulated that they're only for final year, but it might fit in better with those years. I think there was a comment on the community working side of things, Vicky, from Jill Hudson, who has said that in relation to students required to be car driver and hold full driving license but no car, there is an HEI who via a rental service pay and provide for car that students can use. Student pays back the cost of it at the end of the program. Don't know if that's been ever considered or you want to comment on that.
Yeah, so it's actually University of Cumbria have this, and some, Northwest universities are looking at this. So it's something that we've raised within our own university as a way of, because within each program we can probably count on one hand the number of students who have their own cars and have brought them to university. But there are a lot more students that actually do drive. So we have raised it within our university, but within any sector, there are limitations at the moment due to finances, but it's certainly on the agenda and certainly something we're going to continue to push moving forward to look at different solutions.
Thanks, Vicky. I think, Vicky, do you have time for one more question?
Yeah.
So we've got Soraya, do you want to come in?
Thank you, Nisha. Thank you, Vicky, for that presentation. It's just going back to the leadership placements, working with the HEIs locally, because I work in Leicestershire, we're trying to facilitate the leadership placements because all the challenges you noted, we're not actually meeting the number that you need to meet, and we're trying to support that for January. So we've gone down the road of the leadership placement, which nationally other people have done successfully, but the learning outcomes we got, it transpires that it's pretty much the same as a standard clinical placement. So the team that accepted the leadership placement has just kind of taken the student down the route that they'll work with a band 6 instead of a 7 or an 8, because the learning outcomes wasn't there to make it very specific. As that's why I was asking the question, is it because it's the beginning part of the year and they've just started finally in September? I was just wondering whether you had any sort of learning outcomes that we could reflect on, and maybe I can have that as part of conversations with our local HEI, because it takes a lot of time to try and establish these placements, and then if somebody's coming with learning outcomes that's the same as before, you lose the goodwill from staff that's happy to try something different. So if you had that would be really useful, please.
I think the only problem with that is the fact that each university, apart from the 4 in the Northwest that we've got a common assessment document, each university has different assessment documents for their placement, and with each placement there'll be slightly different learning outcomes. So therefore it would probably be best at this time to work with the university around which learning outcomes the student needs to meet for which particular placement, and then try and map your project or leadership type placement into that. So there may be sort of a standard form or a standard pro forma that you can come up with in the future, but it would probably be working with that HEI to find out exactly what learning outcomes they need to address. Does that make sense?
Yeah, that will be my next step, because I appreciate you can't cross it over, but I just wondered whether there was some sort of principles. But that's fine. I can start having that conversation locally. Thank you.
Soraya, can I come in on that as well? So what these leadership placements have done, the existing paperwork that students have for learning outcomes, Where they have a leadership placement, they've basically translated those into a leadership sort of project. So for example, going to say the OT process, what would you first do in terms of gathering information? So if you had a project, where would you gather information from? Would you do a Twitter poll? Would you do a Survey Monkey? Would you go out and speak to people? The next step would be to kind of do that assessment of the problem. So when they're doing a project, they've applied that same step to doing that project. And it's almost been an sort of interchangeable between a clinical and a non-clinical environment, but understanding of that OT process. So that's just one example of how learning outcomes have been the same learning outcomes have been used for a leadership placement. I hope that helps.
Yeah, that actually makes a lot more sense. I can understand where they could have misinterpreted locally then. Thank you.
Okay, thank you. Is there any other questions at all for Vicky before she shoots off? There are no hands up. I will assume we can let Vicky go. If there are questions later for Vicky, you can send them to the project team and we can pass them on. But Vicky, thank you so much for your time today and very informative presentation. Thank you.
Thank you, everyone.
So moving on to our next presenter, we have Sarah Dyson from Liverpool University Hospitals Foundation Trust. Sarah, oh, sorry, is it Malcolm? Have I got it the other way around?
Yeah, I think it's me next, but
okay,
I don't mind.
Sorry, Malcolm. So same trust, but at Aintree Hospital. Malcolm, I'd like you to just introduce yourself to our audience, and then it's over to you.
Thanks, Nisha. So my name is Malcolm Peoples. I'm one of the Band 6 physios in the outpatient department at Aintree Hospital. So we just at the start of this year introduced a new 4 student to 1 physio model in outpatients, partly out of necessity and partly out of just identifying some issues with speaking with the other physios in the department. So I've just been invited along to share my findings and what we've done about it, and because it's turned out to be quite successful so far. So Graham, if I could have the first slide, we'll go through it. So what we found, some of the issues that we found with the old 1-to-1 ratio is that generally we had 4 students at any one time in the department. And as a result of that, we then needed 4 physios to be able to offer the supervision for those students. Now, we do have quite a big MSK department here, but for a few different reasons, sometimes we don't have 4 physios available, whether it be that they haven't had a student before, they haven't done the educator's course, or some of our physios just maybe didn't feel comfortable on top of their normal workload, taking on a physio student to try and look after. So we thought that we needed to try and do something around that. We're also aware, obviously, that the placements for outpatients are highly sought after because we get lots of requests throughout the year, not just from the University of Liverpool, but from some of the other unis a little bit further afield. So we wanted to look to see if there was any way that we could increase the capacity. Some of the other things that we found then was that the physios felt that they were struggling to find sufficient time to support the students, because what we would have done is the physio would have had their own set list for the day. Then they would have picked some of their patients from that list, normally the new patients, for the students to take from them. And then that would free up a 30-minute gap for the student to see the patient and the physio to be free. But that didn't always work out, because sometimes maybe the next patient would arrive for the physio and the student would still be with the previous patient. So to be able to give them that designated time, we felt that we were plugging gaps rather than offering them the full support. Sometimes a lot of our students are supervised by a minimum band 6, and a lot of us band 6s would be doing like MCAS, more complex patient treatments. So some of our patients were maybe above the level of a brand new physio or a brand new student, and they would maybe find that quite difficult to cope with that patient. So then we were finding that some of our students were getting quite overwhelmed, and it was just quite complex for them. Because then they were pulling from our structures and our diaries, it was really just planned on the day, depending on what was coming in. It was really difficult for the student to be able to plan ahead, know what was coming in the next day, do any forward planning, reading around subjects, things like that. So we felt that that was clearly an issue for them. And then say it could lead to issues finding enough physios depending on what other things were going on in the department, whether staff had left, had moved to new positions. Like currently during the COVID redeployment of staff, we've lost quite a number of physios in the department. So reducing the number of physios that was needed for the number of students was making it easier to manage for us. So if we can move to the next slide. Okay, so the things that we've done for planning of the new model. So it was kind of thrust upon us a little bit because we had received a notification towards a bit of last minute about a student that had been swapped out for a different student. And the student that was coming in had some complex learning difficulties that was going to need monitoring and possibly quite a bit of support on the placement. We were a bit concerned that on the old structure, we may not be able to offer that amount of support. So we felt that something had to be done to make sure that there was enough freedom with physios to make sure that that student was going to manage. So that's to say, we identified then the need to free up some physios to have a floating physio in the department so that if that student or any of the other students required some extra support, then we could offer that for them. We wanted to build a model that the students had a clear structure. They were able to plan not only that day, but the days coming the rest of the week and the following weeks for that placement. So they knew what follow-up patients they would have, when they would be. They could book them on the specific time slots and arrange their own diaries to give them freedom to do other things other than just face-to-face patient contact. And we wanted to build a structure that provided the students with flexibility and that they were in control of how busy that they would be. So if they were finding it a bit difficult, they could slow things down a little bit. But also for our students that were really strong and managing very well from the start, they could then be very independent and match up with the mark schemes that we would mark them on. At this time, it was around the University of Liverpool, the Lift Up scheme, which is a lot about interacting with other physios, looking at your diaries, planning your day ahead, looking at the other clinical things that are going on, not just patient contact, and they would be able to manage that as well. And our original plan was just to do it with one physio to 2 students, but then at the last minute as well, we found that with some movement within the department, some of the physios that we were depending on weren't going to be there for that placement. So it all of a sudden became a 4-to-1 ratio. But we thought there wasn't a huge amount of movement from the 2 to the 4. So we thought we would give it a go and see how it turned out. So we go to the next slide, please. So the things that we had to plan before the placement was with a new diary structure, we then obviously had to have some patients booked into that for the students coming. So what we do here is we get online triages that our Band-Aids and AHPs would go through on a daily basis. Anything that we thought from the triage that looked relatively straightforward or simple enough that we would give to one of our Band 5s, then we thought that would be suitable to be given to our students as well. So they would be marked up to our admin teams, who would then book them on to the correspondent. Hello.
Hi, Alison.
Sorry, colleagues, can we put ourselves on mute?
No, you're all right.
Imogen,
I'm just
sorry,
on a training.
Sorry, can you be on mute?
No, it's okay. It's just a general.
Sorry, Malcolm.
Just move away.
No problem.
Yeah, go on. Carry on, my dear. Yeah.
Right, Malcolm, do you just want to unmute yourself?
Can you hear me?
Yeah, we can hear you now. Go on.
So as I was saying, the Band-Aids would triage them. If they were suitable for a student, that would be passed to our admin team, who they would populate the diaries for the students. And we would start off with between anything from 4 to 5 new patients only on that day, and they would have quite sufficient gaps in between times to manage those patients. It was spread out across the day, and we made sure that you'll see in one of the next slides the layout that we had. We were wary that we didn't want 4 new students having 4 new patients all at the one time, and potentially coming out from a patient all needing support at the one time. So we broke it up throughout the day that there was never more than 2 of them with a patient at the one time, and then when the other 2 students would be able to get that face-to-face supervision, support, anything else that they needed around patients, whilst the other ones were seeing that patient. The admin teams had to build some diaries on our computer system. They would have the available new slots to book into. The only people that could book into them would be the supervising physio or the admin team, and they would only put patients in for either the first week or the first 2 weeks, because then that would give us time to review the students, see how they're managing with that workload, and if we needed to fluctuate or adapt it for those students in any way, shape or form. All of the follow-up slots were blocked off, so no other patients could be booked in. And then the students could make them available for their follow-up patients as they move through the placement. One of the things that we wanted to build was a structure that was very similar to the Band 5 experience. And what our Band 5s would get is, in the early weeks, they would get weekly supervision with a senior member of staff. And then as they become more experienced or more comfortable in the department, that may move to every 2 weeks. So we started off partly for their scores. On a Friday, they would have an hour to an hour and a half set aside where we would do their scoring first of all, but then after that, they would then have some clinical supervision for any patients that they hadn't had an opportunity to flag up throughout the week. And then as part of our supervision, we also offer pastoral care, just checking how they are as a person, away from their clinical duties, and how they're coping both in and out of work, which we found was really useful because some of the students had flagged up some stuff that was going on outside of placements that they sometimes just needed to speak about it. Sometimes they need a little bit of advice and support, and just being able to speak to someone about it, they found was really useful for them, and some of the feedback. The final things then that we done in the pre-planning was every student, when they contacted us asking for some information about the placement, we would give them some advice on the things to look at from a pre-reading and how to prepare for the placement, what to expect on the first day. So we just kind of would say things like being prepared for basic subjective, objective assessments, having a basic knowledge around all of the joints and some of the common conditions that we would potentially see in the department, and then we would support them to develop on that whenever they came on placement. Then the final thing is, originally when we were on the 2-to-1 ratio, we were going to have half a clinic list for the physio. But we then decided when we went to the 4-to-1, we shut down the physio's diary for all of that time. So they were always free at all times to be able to support the students where needed. So a week or two beforehand, there was patients being discharged. There was any patients needing further care were moved to other physio streams. And we wound that down as much as possible to alleviate the burden on the other physios in the department as well from cancelling a list. Next slide, please. So this is our original structure, because we normally have 2 MSK only placements, and then we have 2 which are a mix of MSK and our hydrotherapy team. So this was the very first structure that we built. 2 of the students had 1.5 days each of hydro, and then the rest were all in MSK. So this is roughly what the structure looked like, and you can see that at no time throughout the week was there ever more than 2 new patients booked in, so that they had plenty of opportunity to be supervised by the physio at that time. The next structure, please. This was then the second structure that we built, because usually we would deal with University of Liverpool students, but we have had during COVID some Salford students here as well as part of the backlog. They work on a 5-day structure, and I believe that in January University of Liverpool are moving to the 5-day structure as well. But part of the COVID guidelines was that our hydro pool was shut down for this period, so we had to change then to 4 complete MSK placements at that time. Pretty similar structure. There was never more than 2 patients at the same time, and they still had their supervision slots booked in at the end of the week. It was just there was an extra day on top of that of patients. If we go to the next slide, please. So how we then evaluated the model to see if it was successful or not. So on the first implementation, and we still do this now, is we asked regularly from the students' perspective what they felt that the pros and the cons were from it. If there was anything that they felt that we weren't meeting in their expectations, or if there was anything in particular that they were particularly pleased about. We realized that we needed to have there was more adjustments that needed to be made in the pre-planning for the next students, that they were aware, but a lot of it was minor adjustments where they would have liked to have had a little, maybe one less patient rather than the 5 to start with, a little bit of extra time between the patients, things like that. And then when COVID was introduced or came on, we had to move to the telehealth, which the students found it a lot more difficult than face-to-face contact. So then we adjusted the diaries again so that they had a little bit more flexibility and time. We had some patient feedback questionnaires that on completion of the treatment, the students would issue to the patient. They were filled out anonymously and then dropped into our admin team at the front desk. And there was really strong positive feedback from that. There wasn't any major negatives or anything like that. So we felt that the patients were quite happy with the level of care that they were getting as well. We got some feedback from the other physios in the department on what their experiences were. Did they feel that it was beneficial having the students there? Did they see a change in their working day? And a lot of the feedback was that having extra capacity and extra physios in department to help absorb some of their clinical lists when they were struggling was a great benefit to them, which is really interesting. And then we had planned to do some reviews of the waiting lists and outcome measures, but unfortunately they got distorted with the COVID-19 because our lists went on hold. It drove up the waiting times and things like that. But we do plan to do that in future. Next slide, please. So the changes due to COVID. So the biggest one that I'm sure a lot of other trusts have done as well is the introduction of the telehealth. The students really found this difficult because sometimes they struggled to convey over the phone what they were trying to explain to the patient, especially on the objective side of things. They found it difficult just trying to, they've seen a value in the non-verbal communication side of things that they would normally get from dealing with someone face-to-face. They found it difficult to decide whether the patient was happy, whether they were not happy, what they were trying to convey themselves, and they felt that they needed to spend more time with the patient to get exactly what they wanted. As a knock-on effect, this obviously decreased our number of face-to-face patients in the department. So when the students originally arrived on placement, they were concerned that they wouldn't have enough practice of objective assessments, getting their hands on patients and things like that. But we still had face-to-face patients coming to the department. We just had limited numbers due to the social distancing guidelines. So we ensured that when patients were required to be seen face-to-face, students had opportunities to shadow other clinicians. If it was their patient that they felt was someone that needed to be seen face-to-face or urgently, they could be booked in, and they would be booked in a time frame that didn't clash with other patients in the building. And I think we always had to keep our numbers in the building less than 10 patients at any time. But by the end of the 5-week placement, they felt that they had sufficient practice on the face-to-face side of things. And from seeing them with those patients, it was evident that their skills had significantly improved. Unfortunately, we were unable to commit this time round to the pre-planning of new patients because we've had a lot of staff redeployed, and we were in daily flux where we didn't know whether we would have more staff taken to the wards and then some lists needing covered. But we found that the students were extremely helpful in this because they were extra bodies on the ground, that they were able to absorb some of the juniors lists, the band 5 lists, and limit the number of patients that needed to be cancelled or rebooked at other times, which was really useful for us, and the department seen a great benefit in it. In addition to that, pre-COVID wise, we found that our capacities in the department significantly increased. So based on the structure that we were running on the 4-day structure, our new patients per week increased by approximately 64 patients per week. So that was based on 5 patients new per day for each student, and then taking away 4 new patients a day that I would see in my list that was cancelled. So that brought it to 84 in total. And then on the new 5-day structure, I think that increases to about 80 across the week. Next slide, please. So the most important thing for us is that we feel that the students get what they need from their placement. So we were really particular on getting feedback from them. So some of the things that they fed back was they liked the fact that there was always a physio available, floating around, that they could always contact. They felt that there was a form of comfort or confidence in them, knowing that there was always a physio behind the curtain, not far away, that if they were ever in difficulties, that they would always be able to rely on. And even if that physio was then dealing with one of the other students, there would be other physios around the department as part of their mark scheme, where they do a little bit of interaction and integrating with the other physios in the department, that they were able to get that support, but it didn't provide any major burden to the other physios in the department. The students really enjoyed that they were all located together as a team of 4. So not only did they learn from their educator, they learned from each other as well. They supported each other. They discussed patients and how they had managed them, and then learned little things from each other. If there was one student having a clinical discussion with the educator, the other 3 were around, so they had the opportunities to hear the conversations and learn little bits that they may not have experienced to that point. But then when the similar patient arrived, they had then that knowledge behind them from hearing it and getting involved in those clinical discussions. On the first day, when there was 4 or 5 patients booked into their diary, they were initially shocked that they were straight away hit the ground running and have to see patients. They thought it was a little bit overwhelming to start with, but when they reflected on it at the end of the first week, and especially at the end of the placement, they felt that it was a really good way to get started. A lot of them preferred to be getting hands-on, get stuck in, and learn by doing, rather than watching a physio doing an assessment. They felt they were learning a lot more, being supported through, and they always, with their new patients, the very first one, they were never sent into the patient on their own. They were always supported with myself or one of my colleagues who was doing the 4-to-1 ratio at the time. They really liked having their own diary structure, having their own lists, being able to forward plan, move patients around, condense lists so that they could go and spend time with other MDTs. We have some other services that run speech and language, OT, physio, dietetics, all in the same building. So they were able to go and spend time with those. They were able to go over to fracture clinics. They were able to see other clinics that were run while still managing their own caseload and seeing their own patient load as well. Next slide, please. So from the departmental feedback, the biggest thing that we noticed, as I've already said, is the increased capacity for new and follow-up patients. Significant increase on the original structure of 64 new patients per week, which is now from the next set of students due to come out on a 5-day placement, will go up to 84 in a week. And that's helping us massively get through some of the backlogs from COVID when patients were put on hold. And then the students helped in providing cover for the unforeseen circumstances, whether or not it be staff off sick or isolating with COVID, whether it be last minute COVID related meetings were arising within the department, or on a daily basis we were getting staff taken away, redeployed to help on the wards, and rather than having to cancel patients and leaving them unhappy at the last minute, our students were able to help us out and see some of those patients, and it was really, really helpful. Next slide, please. So some of the general comments that I've made or picked up from my time is starting on week 1 with 5 students per day, or 5 patients per day, sorry. It shows a progression through the weeks where they find 5 patients in one day is quite tough, but then by the end of their final week, they're seeing 4 and 5 new patients a day, plus maybe another 4 or 5 follow-ups. So they're then managing close to a full caseload, and they felt that they were managing that quite well. But the graduated progression through the weeks showed that they were getting stronger with their time management, with their patient management, keeping things within the time frames that they needed, and giving them confidence to see how far they'd come along. The structure, we felt, provides the the students loads of opportunity of ways to gain extra marks and to flourish. So looking at their organizational skills from their diary, taking initiative and planning extra activities. If their diary is looking quiet, they can go and seek other opportunities out. If it's really busy, they can start to disseminate and delegate. They can independently manage those caseloads for themselves, and then they can go and spend time in the other clinics, becoming part of the MDT, and different opportunities like that. We felt that it was a very similar structure to what our Band 5s experienced, and it's evident from the first time that we introduced it. We felt that by the end of the placement that some of those students, we would be quite happy to employ them as Band 5s now. They got the similar levels of support with their weekly supervisions. They were seeing similar numbers of patients, and they were managing to the same level without requiring as much support. So we felt that that was really useful for them as well. And then the flexibility and the freedom of the educator with no clinical list just allowed us to manage a number of different scenarios, whether it be some students who have initially struggled on the placement, some have lacked confidence, the one student that we have with quite significant learning difficulties, the pastoral care of some of the students, and then on top of that, we had one student who was sick for a day that when they called in, rather than having to worry about cancelling a full list, that physio was able to then absorb some of that list and cover it for them, and then delegate between the other students as well, so that no patients actually needed cancelled on that day. And that will be extremely stressful if you have a physio with a full list trying to deal with that on top of their own. Next slide, please. So finally, just some of the aims for the future. So like I said earlier, we've recently had some of our students from Salford University. It was the first trial of the 5-day full MSK placement, and they really enjoyed it. They give excellent feedback at the end of the placement, and the educators from the university seem very pleased with it as well. So we're now rolling that on to the University of Liverpool ones in January, who are going to be on their first 5-day placement. We do need to look at introducing the structure for other physios for the future. Currently, it's just myself and then one other physio, because some of the demands I've been asked to help with a new service, so I'm on split working at the moment. So we obviously, rather than back-to-back 5 weeks with the same physio all of the time, closing down those lists, we can rotate it around the department, and there's a lot less demand. But we found that when we do bring in a second educator, we do have to dovetail it so that we don't have two educators in the room to defeat the purpose of the 4-to-1 ratio. But on top of that, that there's not conflicting opinions. So whenever I'm in with the students, the other physio takes a step back and does their own clinical work, and then with the other physio, and then I take a step back and I'm doing my clinical work. But the key to that is just good communication between the two physios to ensure that we're always at the same level and the same opinions of what the students need throughout it. And then we're hoping that the model can be rolled out to other MSK departments potentially across the region, as it may be a help to increase the numbers of placements. But on top of that, we do have some different sites, some satellite sites, and we think there's at least one, whenever COVID restrictions relax and social distancing is not required as much anymore, that we may be able to do another 4-to-1 ratio in one of our other sites, which would mean we would have up to 8 students at any one time. So that's our plans for the future. And I think the last slide is just if anyone has any questions.
Thanks, Malcolm. Thank you for that. That's great. I'm conscious of time, so I'm just going to invite people quickly to ask some of the questions they've put in the chat box instead of me reading them out, if that's okay. Yeah. So can I invite Ross Mitchell? You've got a couple of questions, Ross. So do you want to ask your most pertinent question first to Malcolm, please?
Great. Yeah, so that was great, Malcolm. That was really interesting. So the first thing was just to ask, what you mentioned, a lift-up score. Is that a trust or a university thing that kind of gives you a score of how students or Band 5s are doing? I've not heard that phrase before.
Sorry, Lift-Up is an app that's used by the University of Liverpool. Okay. So it's a 10-point marking scheme, and they get scored out of 10 on a weekly basis, and then they get a cumulative score over the 5 weeks.
Okay. And then the other one was I can't see what I've written now. Yeah, just to see like how many you mentioned that COVID changed things. Had you been
Yes.
through this cycle a few times before COVID came along?
No. So our first introduction of it was we started in February. So the 5th week of the placement ended up finishing early because the national lockdown came in on the Tuesday of that week. So we've only actually had one of it fully up and running of just normal, what we would have called normal face-to-face clinics. Then since that, we moved to a hybrid of face-to-face telehealth, telephone clinics since then.
And that's all in department. I'm just thinking like 4 extra bodies, 4 extra cubicles, or 4 extra devices to be able to do stuff.
Yes. So we're quite blessed with quite a big area of space in our department, but we have had to introduce some changes. So we've got like plexiglass cubicles have been created to get around some of the social distancing. We've brought in some remote laptop situations as well. And we've worked from those, but some of the students, some of our students have used their own phone, but they've been told that they're not required to do that if they don't want to, but a lot of them prefer to do that with some headphones in. Some of our laptops have what we call soft phones, and we use similar software to Microsoft Teams. But because we have such a big department, we have 2 quite sizable clinic rooms and then some gym areas that aren't being used that we would have used for classes. We've been able to spread them out throughout the department.
Fab. Sounds great.
Thanks, Ross. Soraya, I think your questions you've said that have already been answered. So if I can move to Rachel Barker. Rachel, do you want to ask, and this might be the last question if that's okay. If you have any other questions for Malcolm, please do send it to us. And we can direct them to Malcolm. But yeah, Rachel, do you want to come in?
That's great. Thank you, Malcolm. That was really interesting. If you could share your email so we can pest you, that would be brilliant. My question was around, given the feedback and the numbers of patients in the first week, did you consider reducing that? And then the other part was, what did you do with the full caseloads afterwards when the students had finished? Because obviously that's a lot for you as an individual to take on.
Yeah. So first of all, we have adjusted the new patient caseload since COVID came in. The first cohort felt that the 5 in a day was manageable, so we originally hadn't changed it. Our second cohort that were purely on telehealth at that point, they felt that the 5 was too much. So that's why we introduced the only booking for 1 week of new patients. So then we starting with 3 to 4 new patients with an hour of a gap either side. So they had loads of time to run over if they needed to and get their notes completed. And then we just gave the students the freedom to make their diary as busy as they wanted and build it up. We encouraged them to build it up each week. So we tried to get them that if they finished the previous week on 5 patients per day, that they would aim to start the next week on 5 patients per day and build as the weeks went through. But we always stressed that because I was floating around, I had the ability to take a patient off them if they felt that they were becoming overwhelmed. But a lot of them tend to manage it really well. And what was the second part of your question?
It was just what you did with the full case.
Oh, yes. So some of them became my own caseload, but we disseminated them throughout the whole department. So a lot of the because they were seen weekly for 4 or 5 weeks, a lot of them had already achieved discharge. But any of the other ones were just disseminated throughout the department. So the physios, we have a really big department. So there was never more than 2 or 3 patients per physio that they had to absorb. And then the students would give full handovers with plans and let them continue on with the treatment from that side. But because my clinic was originally closed, I had quite a large capacity to bring on quite a few of the patients and was relatively familiar with them from dealing with them alongside the students. So it wasn't the same as me just taking on a new patient that I knew nothing about.
Yeah, that's great. Thank you very much.
Thank you. Thanks, Malcolm. Are you hanging around for the next presentation, Malcolm?
Yeah, I'll stay.
Okay, thank you. Thank you. That's great. So with that, I'd like to invite in Sarah Dyson. our final presenter for this afternoon. Sarah, if you want to again introduce yourself and any colleagues who are there with you today for this presentation, and I'm just going to hand this over to you. Over to you.
Okay, thanks, Nisha. Can you hear me okay?
Yeah, we can.
Yeah, that's fine. Just that we're a little bit away from the microphone, that's all.
Yeah, I was just going to say that sorry, Sarah, it feels you're in a bit of a distance. So if you can move a bit closer to the mic, that may help, but we can hear you. It's a bit faint.
The what, sorry?
The lead is quite short, come closer to the... Right.
I think I'm just going to have to sit on top of it. Is that better?
Yeah, that's a bit better, actually.
I'm trying not to wreck my boss's office. So yeah, oh look, I've missed my name off that slide. So I'm Sarah Dyson, I'm a clinical specialist in critical care on the Royal site, and I'm here with Jenna, who's one of our Band 6 staff, and Dimitri, who's one of our assistant staff, and they have been working on this project of a 3-to-1 model of student placement provision. So Jenna's going to go through the slides which talk about our experience and the student experience, and then I think Dimitri's just going to give his perspective as an assistant at the end as to how it was for him being involved in the supervision and support of students. Thanks, Jenna.
So if we could move on to the first slide. Okay, so just to give some background on how we ended up implementing this 3-to-1 model. So we had 3 students from the University of Liverpool due to start placement with us in the respiratory team simultaneously. And we had a bit of a challenge in terms of we had a reduced number of clinical educators available to support them. We've got some really experienced therapy assistant staff on the team. And of course, we've got some challenges specific to COVID at the moment and the provision of placements. So a decision we've kind of taken as a team is to limit the students to working within the green areas, the non-COVID wards, to keep them safe. Some of the infection prevention and control measures, just thinking in terms of people not crossing too many wards, keeping everybody safe. There'd be a requirement for the fit testing and FFP3 mask issues if we were going to put students into COVID risk areas, which has been quite a challenge for our permanent staff. So it wasn't something we were looking at opening up for students as well. Next slide, please. So the model, so 3 students to 1 educator, but in practice it wasn't quite as clear-cut as that. So it ended up more like 3 students supported by me, Band 6 physio, plus a Band 3 therapy assistant, plus a lot of input from a Band 5 physio and another Band 6 physio who comes in on my days off. So I work 3.5 days a week. So there's another physio who supports the students when I'm not here. So yeah, not quite as straightforward as 3-to-1 in the end. And the students were placed on elective surgical wards. So we planned, at the beginning of this, we planned that the 3 students and I and Dimitri, our assistant, would cover 2 surgical wards with the plan that they would pick up the caseload between them and take, 2/3-ish of a ward each, and that we'd all be in close geographical proximity, so I could kind of flip between the wards and everybody be nice and close with each student. So next slide, please. So I'll just share some of the feedback that came from the students. So the positives of the 3-to-1 model in their view. So They felt it was easy to ask for support when it was needed. So, you know, there was a lot of presence of staff around. It was always, you know, they weren't just kind of left floundering on the wards. They felt well supported in their individual learning needs and goals, and that we were open as a team to providing new learning experiences. They felt there was good continuity of working with the same staff who then fed back into the educator, so into me, and that there was a good balance there of flexibility and consistency. So just to kind of go back a little bit on how the model was actually implemented in the end, it kind of evolved in the first couple of weeks. So we had the plan that the 3 students and me would be working across 2 wards that are adjacent to each other. As it turned out, with COVID, so this started about a month ago, and at the time lots of elective surgeries were being cancelled, so the wards were very quiet. So in order for the students to actually pick up a decent caseload, it ended up that one of the students started working with one of an experienced band 5 on another ward, so he's spent quite a lot of his time with this band 5. So whereas we had that plan for all of us to be across those 2 wards, it actually ended up that one of them had gone downstairs on 1 floor. So just adding in sort of that a little bit more of a challenge in terms of me still being the educator who's giving the assessment, but needing to take in feedback from this other physio, as well as taking in feedback from the assistant and the band 5, the band 6 who works when I'm not here. So there was that issue of me taking in feedback from multiple members of staff. But the students felt that we had some, you know, good consistency and continuity on that front. They felt that the model offered freedom to take responsibility for their own caseload, and that it helped to build trust between the educator, between us and them, and building up their confidence and their sense of progression. And they really seemed to take a lot from that kind of trust that we're putting in them to manage their own caseload. They felt that they gained wide experience from working with different physios and other professions, and a mix of members of staff. They felt that the involvement of multiple professions and multiple people and physios added value to their lift-up assessments, which was quite a nice finding for me to read, because I think I'd been a bit more concerned that they would think the opposite, that they would feel that there wasn't that consistency there, and that spending time with lots of different people would take away from their lift-up assessments being consistent, but actually they saw a lot of value in it. And they also said that they enjoyed having each other around for that peer support, which I think is something that Malcolm had mentioned in their experience too. So next slide, please. So some of the suggestions for improvement from the students were that we could, in future, maybe look at marking the students on different days of the week in order to manage the time demands, because that was a bit of a challenging area in trying to get 3 assessments done on the same day, and it taking a whole afternoon of my time essentially. They said there's some potential for a lack of continuity and consistency in marking when there are multiple team members involved in feeding back into one assessor, although they felt that we'd managed this well. And some improved communication within our team around expectations of the students, which I think it kind of evolved as the weeks went on, where we all kind of established the expectations of each other and our roles within this model. And next slide, please. So from our point of view, the pros of the 3-to-1 model. Of course, that it expands our capacity to take students on placement. And it's an innovative approach, something we haven't done before. It gives flexibility to the team. It's we've found a really good synergy between the roles of the Band 6 educator and the therapy assistant role. It's been something that's developed over the weeks, I suppose, but I think we feel now that we've got quite a good rhythm and good understanding of sort of where each other's roles lie. So, and safety, so as I touched upon at the beginning, it's, we wanted to keep the students safe and in non-COVID areas. So bringing in this model has allowed that to happen. So they've been working on the silver postdoc boards. Again, in the infection prevention and control, we've minimised the movement going from ward to ward of the staff as well as the students, so kept us all quite kind of localised. And it's given them really good exposure to working with different staff members as well as different roles and teams. So as well as working with different physios, they've worked with OTs and other therapists and worked really closely with therapy assistants, and it's bringing in advancement of the Band 3 therapy assistant role and upskilling that role. Next slide, please. So some of the cons of the model that we've experienced this first time, as I mentioned, that just that unpredictability of the caseload because of COVID. The wards were quieter than they normally would be, cancelled surgeries. So at the beginning, we weren't able to pick up the caseload that we wanted to with the students. Another thing that we sort of hadn't accounted for necessarily is that the students, they're final year students, but they have missed a lot of the clinical hours. So I think 2 of them have missed 2 placements and 1 has missed 1 placement. So up to 10 weeks of clinical placement missed over the summer because of COVID. So just that they're not necessarily at that sort of level of experience that you would expect them to be at in the 3rd year. As I mentioned, doing the 3 lots of a lift-up assessment on the same day every week is time-consuming, and it needs consideration in terms of, if it's going to be one person who's essentially off clinical duties for half a day a week, that needs to be planned in advance for, who is going to be on the ward supporting the students. And so the organisation at the beginning of the placement. So as we've kind of gone through this, we realised we needed a more kind of structured approach for staff members to return feedback to the educator. So I think initially it was just kind of asking for verbal feedback, but we kind of realised that wasn't going to be specific enough, and in where we want to give the students a fair assessment and be able to properly link it to their marking criteria, we needed something a bit more robust in place. Next slide, please. So what did we learn? So this feedback process, we need a robust process in place for team members to give feedback to the educator and to give people time assigned to do this, and I think a bit of an expectation of how frequently and when is a helpful time to do this. So as I said, I think it was kind of a bit more of a casual ask in the beginning, But as we've gone on, we've developed a performer that's aligned with the Liverpool Uni marking criteria. So it's divided into 10, I don't know what they call them, but it's sort of, yeah. So 10 criteria, and then they each get marked on a scale of 1 to 10, going upwards based on sort of how consistently and with how much prompting and how much complexity they're doing these things. So the form that we've come up with, I didn't think to actually share it on the slide, but it's quite just a simple table of each of these 10 criteria, and a column for a suggested score, and then a column for comments, so that anyone that's essentially spent clinical time with the students can just write me a couple of sentences, as specific as possible, just to give me specific examples to put towards marking. So I think if we did this again in future, that would be implemented from day one, and it made clear to anyone involved that that's an expectation, rather than just kind of that we're just going to casually ask for a bit of verbal feedback. The second point is I think we learned that we need to be prepared to be flexible and to adapt. It's, as I said, this kind of evolved as the weeks went on. That there was one student who, on the third week, moved wards just to allow each of them to take on a bigger caseload. And there was a redeployed member of staff working alongside the students on my days off. So just kind of having that flex within the team in order to kind of account for those things that that you can't always predict. We've found that we've needed just to really take it as a team approach. So one of the things has been that we had a bit of a teaching timetable. So lots of the physios in the department, so they've each done a bit of a mini in-service for the students. So it's kind of, I suppose it's taken that bit of a village approach where the whole team is just contributing a little something. So it's not, okay, it's a 3-to-1 model, but it's not that one educator is going to be able to provide all of the teaching and all of the clinical experiences. It's kind of drawing on the skill within the team, and just asking that little bit of a contribution from the wider team. Next slide, please. So what would we do differently next time? So I mentioned a teaching schedule that was kind of implemented, I think, in the second week, and we came up with a timetable and asked staff to contribute to that. I think next time we know that we would need to have that planned in advance to give staff the time to prepare and to plan their caseloads around that time commitment as well. And similar to that, the schedule around interprofessional learning, we would want to have that organised in advance. So things like the students spending a half day shadowing speech and language therapy, for example, or any time that they spend, so that they each spent some time on critical care. So that's when there are 3 students, it all of a sudden becomes quite a task, just trying to get all that sorted and trying to find, the team's capacity for taking it on ×3. So having a schedule for that in advance would be helpful. And as I think I mentioned earlier, the planning of caseloads on assessment days. So where that's all going to be done on one day, planning in advance for the fact that's going to take a lot of an educator's clinical time, limiting any other competing commitments. So I think there was a day when one of the students was spending a morning shadowing with speech and language, and then in the afternoon we had the students' assessments. So in terms of a couple of people having quite a lot of clinical time taken out of their day, it's just managing those things and a bit of forward planning around that. Next slide, please. Well, that might be the last one. I'll hand over to Dimitri, our therapy assistant, to just give his perspective.
Hello, everyone. My name is Dmitry, so I'm a band 3 therapy assistant within the respiratory team. Been with the team for the last year plus, I think, so plenty of experience, and it's my 3rd year within the trust. When I got approached with this project and got offered to take part in it, I got quite excited as I saw it as an excellent and unique opportunity to look into my own weaknesses and strengths and evaluate them and work on them, while possibly learning a bit more myself while I'm teaching the students. So yeah, quite enjoyed the experience, I have to say. It did test my major weakness, which is the public speaking. So having prepared a little presentation for the students, I think we've missed it in the main part, our in-service trainings. We've pulled together quite a few of other colleagues and asking them to prepare presentations on certain topics that we felt were most relevant to our students. And it was an interesting experience as well to get all of them together and make their individual inputs in this way, in an organized, structural way. So I enjoyed doing my presentation a lot, and yeah, got a few compliments from the students as well, saying that it was very informative and I held myself well. So that meant a lot to me personally on that front.
That's the end of our presentation, so I'd like to thank Dimitri and Jenna, and if anybody's got any questions, we'd be happy to take them.
Thank you, Sarah, Jenna, and Dimitri. So I'm just making sure that I'm conscious of time. We have slightly run over. Are you still okay for questions, Sarah? Yeah.
Yeah, absolutely.
Okay, that's great. Does anyone have any questions for Sarah, Jenna, or Dimitri at this stage? Just put your hands up again, please. While we wait for others, can I just say that it sounds like it was really a team approach from your end, wasn't it? It wasn't just down to that one educator, Jenna, to yourself, but it sounds like you kind of employed the whole team into this. Is that right?
Yeah, absolutely. I think it's I think that's kind of the only way it could be achievable, really. Yeah, so as I said at the beginning, it wasn't quite as straightforward as 3 to 1. It was sort of lots of smaller contributions from lots of team members.
Yeah, fabulous. And it sounds like Dimitri really enjoyed what he did as well with the students. And is that something you hope to keep on going forward?
Yes, I quite enjoyed it, and I think the placement was a success generally. That's what our consensus is on our side, and that seems to be the consensus on student side as well. I'm sure that we could do the next lot, help them even better and support them even more appropriately. Particularly, I think the main thing that would need addressing, I think, is the structural withdrawal of support. As you support more of them on the first week and you take more and more, so by the end of the last week, they pretty much organize their own caseload from the morning and come to you asking for support as necessary.
That's great. So if I don't think there's any questions coming straight away, but if there's any that come afterwards, we'll send them to your direction if that's okay. But with that, I'd just like to call a close on this. Thank you everyone who has attended, but especially obviously to our presenters this afternoon for taking the time out of your busy schedules to be able to share what you've already done. We will be posting a link of this on our Twitter page, but also send it out on emails with the slides of today's presentations to all who've put their email in the chat box. Just on a last finishing note, if you are part of Cheshire, Mersey and Wirral and want to be part of the clinical placement expansion project work streams, please get in touch. The project team's emails are on your screen now. There are 13 organizations who are part of this, but if you're not part of them, but still within Cheshire, Mersey, Wirral, you know, you're most welcome. So yeah, thanks very much, everyone. And if we don't see you again, have a lovely Christmas and New Year's. Thank you.